And hello. Hi, everyone. My name is Chris Urbanek. I'm a physician for Regenexx Des Moines. Welcome to our lunchtime webinar. Today, we're going to be covering some hip issues and kind of what our treatments would look like to help with hip, kind of compared to what some of the other treatments are that are out there. And we'll look at some of the evidence involved in all of that. So if you bear with me, we're going to open up our PowerPoint and we will get started. So let's take kind of a basic look at the hip anatomy first. And so the picture on the left is an X-ray of the actual hip joint itself. And then on the right is kind of a schematic of really what we're looking at. So if we go to the schematic first, primarily we can focus on the thigh bone, because the hip joint is really just the articulation between the thigh bone and one of the pelvic bones. And so the femur kind of is the vertical shape on both sides. And then you can see the neck, which is the transition from kind of the shaft of the femur to the neck, and then to the ball, which is the ball and socket joint. And the X-ray looks identical, right? So shaft at the bottom, neck of the femur, ball and the ball and socket joint. And then you have kind of the receiving end on the pelvis, which is the acetabulum, which again is just the socket side of things, and that's on both of them. Now, there's some things that we can't see on X-ray, like cartilage. So I can't see the cartilage that's causing there to be space between these two bones. And that's what the gap is between this white line and this white line. This is what cartilage would fill in. We also can't see a cartilage rim that kind of lines the joint like a triangle. And so if even looking on this side, it's marked as the labrum, and that is this cartilage washer that gives increased surface area and helps hold it together. And it wraps all the way around the front of the joint, down the bottom, the back side, which we can't see, over to the top, and then back to the front. And that's the labrum. Like I said, this is a cartilage washer that gives more contact area. And that's basically the hip. Now, this pain, again, so out here, this is part of our iliac crest that we're just starting to see. This is our thigh bone, which you can feel kind of on the side of your own hip. And so we're more medial to that. We're closer to our belly button. So oftentimes hip pain from the joint is going to present as more groin type pain, or pain that goes back towards the buttocks, or pain that goes down into the thigh. It's not uncommon that patients will say, oh, I have hip pain, and they point to this area that's kind of out here on the side of their femur. And yes, that's the hip region for sure, but the actual joint is a little bit more central to our bodies than that. We'll talk about some of the issues that can happen kind of on the outside or lateral aspect of the hip joint as well, that can cause some issues. And so again, kind of the first thing that we're really going to focus on is osteoarthritis, because that's one of the more common things that we see. And we're going to kind of take a deep dive right off the bat into some science heavy literature. And so one of the things that I'll often talk about with my patients is, just because you have arthritis in one joint doesn't mean that every other joint is going to respond the same way. And one of the things that we see with hips in particular is that they tend to progress very, very quickly. So while knee osteoarthritis can kind of smolder and take some time and just be a nuisance for years on end, hip osteoarthritis usually presents a little bit different. It usually presents as that sore, achy pain, and it can often be fairly late in the course when it's first diagnosed as osteoarthritis. And so, or if not, even at the beginning, when we catch it mild, I tend to see this progress a lot more quickly than we do with the arthritis in other joints. And this is a great study that is very heavy in science. But what it looked at was some of the chemicals that are involved with how does our cartilage heal and how does it break down, and what's the process that the joint goes through to kind of maintain that cartilage. And in this study, they found that the knee joint tends to have more of the molecules inside of it that help preserve cartilage or help fight some of that degenerative change. Whereas in the hip, it doesn't have as high of concentrations. And that fits clinically with what we typically see, that the hip joints tend to progress a little bit faster and can be a little bit less resilient to treatment. So this is kind of the osteoarthritis side of things. And one of the reasons that again, we want to be a little bit more aggressive with treating hips, as opposed to kind of letting it go for a while or doing more of a wait and watch. But what are some of the other treatments that we'll see kind of done that are not our approach? A very, very common one is corticosteroid injection. So if you're watching this and you have hip pain, your surgeon may have said, hey, why don't we try a hip injection, which should be done either under ultrasound or fluoroscopy. And let's see if it moves your symptoms. Now, this is a wonderful study that was done in a very, very big journal, so high published. Your surgeon has likely heard of this, which is kind of crazy. But this is the Journal of Bone and Joint Surgery, which is a major orthopedic surgery journal. And this was a study looking at hip injections in patients with hip osteoarthritis and what were their outcomes, particularly with one of what we thought was a fairly rare side effect called rapidly destructive hip disease. It goes by a couple of different names: rapidly progressive osteoarthritis of the hip, rapidly progressive OA. It goes through different names, but in this article, they're calling it rapidly destructive hip disease, which basically means that a point where the hip really stops functioning. The bone gets hurt, the cartilage degrades even faster, and these patients are essentially on the fast track to hip replacement. And so what they looked at was patients that were getting hip injections, and they really looked at two things that they tied in concert. They said, one, well, what's the dose of steroids that they've been getting exposed to? And number two, how many injections have they had over time? And so there's a couple correlations here. So if we look just at those topics in isolation, low dose corticosteroid injection, which they defined as less than or as 40 milligrams of triamcinolone, very commonly used steroid. We saw a rate of this rapidly progressive disease in about 3% of their patients. But when they switched to a high dose, we saw the number go up to about 7.5%. High dose they defined as 80%. I can tell you from my experience working in academic institutions, working with my orthopedic colleagues, I don't think I've ever seen a hip injection with 40 milligrams. What they're saying is low dose. I almost always see it at 80, and I've seen some surgeons push it to 120. So this is very modest. And then when we look at just number of injections, regardless of what the dose was, if you only had one injection, you had about a 3.5% chance of having this rapidly destructive hip disease. If you had more than two, your chance goes up to almost 10, about 8.5. And then really we put it all together and say, if you're getting multiple injections, so two or more of the high dose, which is, like I said, most commonly seen in practice, your chance of having this rapidly progressive hip disease goes up to about 10%. And so this is a huge study, wonderful outcomes. Like I said, in a big journal that many surgeons are seeing. So if you're getting steroid injections, they should be consenting you and giving you adequate information that, hey, 1 in 10 patients that receive multiple injections at 80 milligrams or higher will have rapidly progressive joint arthritis that will almost certainly require hip replacement. And that kind of makes sense for surgeons. I'm not trying to poo-poo the specialty, but their job is to do surgery. And so they can handle those complications. But then the question becomes, should they be managing the conservative side of things if it's going to push patients more towards surgery? So this was a very, very big study, came out in November of last year. So a little bit more recent information. What else? When we talk about replacements themselves, let's talk about the outcomes. Now, this is also taken from a large pain study, looking at patients that had both hip replacement and knee replacement. So on the graph here, there's some markings. We'll address those in a second, but let's just look at kind of the two different bars that are on this graph. The darker gray is patients that have had hip replacement. The lighter gray is patients that have had knee replacement. And I'm pointing that out because really we're just going to focus on the dark bar, the patients that have had hip replacement. And it's of those patients, the total number of patients in the up and down direction, what was the level of pain that they had between 4 and 6 months after surgery? Because many patients think, oh, I'm going to be pain-free. I have many patients tell me, oh, I think I'm just going to go ahead and have the hip replacement, as if that's going to take away all of the symptoms. And it's not. So what we see is, the number of patients that have pain after surgery is not primarily in the 0 to 1 group. It's actually more patients you're more likely to have pain than not have pain at 6 months after your surgery. And the exact numbers are about 66%. And so, like I said, 2/3 of patients are still going to have pain. Some of these, again, you can see numbers going up into 4, 5, 7s. So somewhere more in this area is the greater likelihood of your outcome as opposed to being in this first group. And what's interesting is it's not just relatively mild pain, it's pain that 65% of those patients are saying was enough to limit my activities. So again, it's one of those things that I hear from patients a lot, say, well, I think I'm just going to pull the trigger, I'm just going to get the hip replacement, because in their mind they've been told that they're going to have no pain afterwards, and that's not entirely true. And there's wonderful studies that show that that's not the case. As we talk about hip osteoarthritis, which is thinning of the cartilage on the top of the bone, we need to talk about some of the changes to the actual bone itself. And one of the things that surgeons have gotten very interested in the last 10 to 20 years has been this impingement, this idea of, oh, I have impingement. And so what does that really mean? It means you can get in a couple different flavors. One flavor that we call CAM is you have increased bone thickness on the femur side or thigh bone side of the joint. Another one is you get increased bone thickness on the pelvic or acetabular side of the joint. And then another flavor is you get it on both sides. And so this is thickening of the bone that most patients are telling me that they're being told that these bones hit up against each other and that's what's causing their osteoarthritis. And the labrum, which we talked about kind of in that very first picture, sits in this area. So if you have more bone, it's going to smack against the labrum and you're going to see labral tears as well. And so what's interesting is, how much is this actually causing their pain or how much is this adaptive? And if you've listened to some of our other webinars, we talk about stuff like meniscal tears. Meniscal tears in the knee, as long as they're not mechanical, meaning causing locking type symptoms, are just about as common as wrinkles and receding hairlines. It's part of accumulation of years and wear and tear. And they're not something that need to be cut out. And the data supports that. And really, when it comes to the labrum and impingement, the data is supporting that those things are likely more adaptive than they are destructive, meaning that the body has done that as actually a protective mechanism, more so than a sign that things are getting worse. So as we kind of look at one of these, I love talking about this study. This is one of my good partners in sports medicine, Matt Silvis. He's up at Penn State Hershey. It's a little bit of an older study, but I do still think this is one of the first ones that was done looking at in patients that don't have hip pain, how many of them have abnormalities on MRI? And so what he found in his group looking at hockey athletes was about 75, 3 out of 4 patients that don't have hip pain will have abnormalities on their MRI. And so what does that mean? Does that mean that they're just super athletes because they're focused on their sport and they're being tough and saying that they're not having pain? Or is it more likely that these findings aren't necessarily the thing that's causing pain? Or we really need to be calling labral tears and impingement signs pathology, or are they merely adaptive or modifications to the body? And this is repeated in additional studies. This one's much more recent, in a huge study of almost 2,000 patients that don't have hip pains, and they're non-professional athletes. So they have no motivation to say, oh, I don't have pain, I'm covering it up. And they look specifically at the impingement findings. They did not go into kind of the labral findings like Dr. Silvis did in his study. And what they found was about a third of patients, so a quarter to a third, found either one type or the other, which means about 50% of patients, when you add them back, the CAM type plus the pincer type, you'll see that's about 50%. So half of these patients had signs of impingement, but had no symptoms associated with it. I've seen this in individual patients. I've seen patients come into my office and they say, hey, I've got right-sided hip pain. I've been told I've got this right-sided CAM impingement. And then I look at their x-rays and I go, well, tell me about your left hip. How's your left hip doing? And they say, no problem. Haven't had any issues ever. And they have the exact same CAM impingement on the left hip. So I've seen these things even in individual patients. So they may not be the thing causing the pain. And the same thing happens when we look at the labral tears. There's multiple studies that show that the finding of a labral tear on MRI does not correlate with the patient's pain. We've looked at dancers, so asymptomatic dancers. We would think that, symptomatic dancers. So these are dancers who are saying, ouch, my hip hurts. When we MRI all of those dancers, we found that they had a no higher rate of labral tears than dancers that are asymptomatic, suggesting again that the labral tear is probably an adaptive change as part of their sport. The same thing happens in shoulders. If you're a professional baseball athlete in a throwing position, you will have a labral tear. The data shows that you will. It does not mean that it'll be symptomatic, but it's an adaptive change. Or if you're a swimmer and you're in an overhead stroke, you are going to have labral tears, but they may not be the thing that's causing your symptoms. And so that's why kind of part of our process is looking at the whole picture. Again, you can go on, all of these hips demonstrate labral tears but have no symptoms. And then even with injections, the presence of FAI, which is our impingement, or the labral tear had no impact on whether the patient got relief or didn't get relief. And the scary thing about this study is this is retrospective, meaning these are patients that saw a labral tear on MRI, had a diagnostic injection, it didn't change their pain, and then they went on to surgery. So that means that someone's operating on patients that is not pointing in the direction, even the studies that they're having, as being the cause of their pain. So this is very common, and again, huge journal. This is arthroscopy. So every surgeon that goes into a joint with a camera is familiar with this study. Let's talk about the other side of things. As I was saying, that can some of these changes actually be protective? And yes, that's what we think they are. And so this was a great study in a cartilage journal saying that they found no association with the presence of a pincer deformity, and it might have a protective effect on its development. And so this just seems so counterintuitive, because the common medical perception is that stuff like bone spurs are bad. Bone spurs are the thing that's causing your symptoms. And outside of some very rare spine cases, that's probably not true. We think that the bone spurs are probably more protective than anything else, and they're likely secondary to the osteoarthritis, not causing the osteoarthritis. And they're also secondary to instability. So if we kind of really simplify a knee joint, which is, again, I know we're talking about hip, but just for demonstration, the knee joint is a bone on top of the bone. And if there's instability, if there's a tendency for those two bones to want to move back and forth, what the body's going to do is lay down lips of bone on either side. So now there's more contact area, because if it gets too unstable, it starts to kind of fall off the edge. And so, that's a very simplified example, but it's one of the reasons we think that the body actually creates these, is not because it accelerates the osteoarthritis, but the body's trying to do everything it can to make the joint more stable. If you've ever met with a Regenexx doctor, one of our core principles is stability of the joint and making sure that everything is kind of where it should be. So this is a great study that correlates with what we're doing as well. And then, the outcomes from surgery for impingement and labral tears are quite low. And so this, again, KSSTA, knee surgery, sports, traumatology, arthroscopy, very, very large surgical journal. So these are the people that are doing the actual surgeries as well. And when they study their outcomes, they're finding in about half the patients that have debridement of these labral tears have a poor outcome. So not average, not good, not great, not excellent, but a poor outcome. And so everyone else falls into not that, right? And of those, or of the total patients, a quarter of them required second surgery, and a fifth of them said that their hip is now abnormal as a result. So, when there's a surgical procedure, basically removing tissue. And so our goal is to treat these things without. And so we can do that a couple of different ways. I'll show you kind of what our typical outcomes are. So again, I have to go looking in the literature to find what the surgical outcomes are, because they don't keep it public the way that we do. So here's our outcomes. And so these are single treatments of patients with hip pain, hip arthritis, tendinitis, and after a single treatment. And that may be with our treatment where we use concentrated platelets. So from the whole blood, we take the platelets and inject them into the area, or from bone marrow, which we would harvest from the back of the patient's iliac crest, and we inject those cells into the area to treat it as well. And so on average, we're seeing about a 50% increase in function and a 50% improvement in pain. We're actually a little bit higher than 50% over the course of about 4 years, and we get long-lasting improvement. Another one of the reasons that patients that have had hip surgery continue to have pain is because the tendons aren't being treated. And so if the joint was unstable, which happens with osteoarthritis, the tendons start to work into overdrive, and we need to get the tendons stronger. So that's typically part of our treatment protocol, but the surgeons aren't replacing the tendons, they're actually cutting through them, which makes them even weaker. So now a joint that's not the patient's, a prosthetic joint that's already not normal anatomy, is going to be even looser because the tendons can't do their job. And we had to, they cut into the capsule. They have to open up the joint space to get the prosthesis in. So that's kind of part of our approach, that we treat multiple areas that are engaging the joint, that provide our symptom relief, and that really get us the best outcome. So that's kind of a look at hip pathology and a couple of the factors that are associated with that. I do have some questions that were sent, and so I will be happy to read off some of those. And if anyone in the audience has questions, please feel free to go through them. I will start to go through a couple of these now. You can submit your questions to the chat. Our first question: how long is the recovery back to regular activity? And so that's a wonderful question, because that can vary, in that we need to first define regular activity. For many of our patients, you're getting back to your day-to-day, walking around the house, going to work within the first 3 to 4 days. And you're able to do that. Now, you'll be sore, but you're going to be able to accomplish those things. Some patients will define their regular activity as going golfing 4 days a week. That may take a little bit longer, and it's going to be dependent on where in the body that we've done our treatment. So, to get back to golf, shoulder is going to certainly take longer than other areas. And so it's dependent on that area as well. So, but for the most part, like I said, about 3 to 4 days post-procedure, you're going to have increased soreness and able to get back to work at that time. To get back to athletic activity is usually somewhere between 6 and 10 weeks. And like I said, it just varies on what that activity is, what the level of participation was, and what areas we treated. I have a question. How is what you do different from Synvisc injections from orthopedic physicians? This is a great question. And it's one that we get a lot. So Synvisc, if you're not familiar, is a brand name of hyaluronic acid, which is used in injections for many joints. It's FDA approved for the knee, but has been used in shoulders and hips as well. And it's hyaluronic acid has an anti-inflammatory effect without being a steroid. So it's much, much safer than steroid injections, but it has limited kind of effectiveness as well. In some instances, I think it can be useful, but when you look at outcomes, it's FDA approved for every 6 months. And that's because that's about as long as you expect to get any results from it. And many patients are short of that as well. So what we do is we're using your own biology. We're using the cells that naturally heal in your body to create a healing response. And so whether that's platelets or bone marrow cells, and again, you can see from the data that I presented, we're getting much longer outcomes than about 6 months. So I would expect to see a big difference between the two. And the other thing is, the other difference is I see a lot of these viscosupplementation injections being done blind or landmark guided. So the physician feels on the area, places a needle without something to confirm where the tip of the needle is, like ultrasound or fluoroscopy. And particularly these viscosupplementation injections really should be done under imaging. There's some reports of them having calcific changes, or crystallizing rather, when they're not injected into the joint, if they're just in the fat pad. Steroid's a hand grenade. If you get steroid close enough, it'll have an effect because of the way that it interacts with our cells. But stuff like viscosupplementation really should be done under guidance. Everything that we do is under guidance as well, because the cells that we inject are very sticky. They react to collagen. And so if you're not using guidance and you're not in the exact right spot, those cells will not have any effect on the area. And so that's why the guidance is so important. So just another difference as we kind of brought that up. I have another question. I will paraphrase. A patient says that they need a hip replacement, but their spine has been really bothering them as well. And then had a second question, which is 10X the same as Regenexx? So the one thing that I want to address is the spine really bothering. Part of our approach is treating the whole patient, and issues with the spine, nerve impingement, can affect the way that our muscles fire, which can contribute to some of that instability. So we really want the spine to be doing its job. That's like the control box for the system. And so if there's issues with the spine and we treat just like a tendonitis or an osteoarthritis, we don't see as good of outcomes than as if we treat both. So that's certainly something that we focus on, and something that I would encourage that if you're seeing someone, that they're looking at you as kind of a whole system. And then the question about, is 10X the same as Regenexx? So 10X is a brand name for a percutaneous, meaning through the skin, ultrasonic cutting device. And so what it does is it debrides tendons by using very, very fast waves of ultrasound. It's a great modality. We have used it on patients as well, but it is not an orthobiologic. It is designed to debride or get out damaged tissue by using mechanical force. We do the same thing by using a physiologic or biologic force, letting your cells take care of it. And they can be used in conjunction. So not the same thing, a little bit different for sure. And then I'll just point out, I did have another question that says same thing, hip pain coming from spine. Absolutely, have your back evaluated. It's so important. You'll have much better hip outcomes if we're making sure that there's no issues in the back that are contributing to it. So I'll take a quick look through the chat, see if there's any questions. Otherwise, I believe that may be it for today. And if if there's nothing coming up, then I'll thank you all for joining us. Really great. I hope you enjoyed it. And if you have any questions or if you have any areas that you'd like us to cover, please feel free to reach out to me. Otherwise, I hope you all have a great day. Take care. Bye-bye.